Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha and we are back today with another question drill. Today we're going to be covering endocrine questions. So this works just like the normal way we do it. You're going to be presented with a question. You'll have a few seconds to answer. Make sure to drop those answers into the chat below. We have the fabulous nurse Coley moderating for us. Drop your answers in the chat as well as any comments or questions that you may have as we go along. A couple of housekeeping things before we get started. Follow us at UWorld Nursing on whatever your preferred social channel is. We post all of these question drills to our social media after we're done. So if you miss something, you want to go back through something, you're always able to use this as a future reference. With that being said, let's get that chat started by letting us know where everyone is joining from, regardless of if you are a stateside viewer or an international viewer. We're so happy to have you here with us today. And with that being said, let's jump to question number 1. So here the nurse enters a client's room and observes the client is diaphoretic, lethargic, and disoriented to place and time. Which of the following actions would be a priority for the nurse to take? Is it administer IM glucagon, administer IV regular insulin, prepare the client for a CT scan, and obtain a capillary blood glucose level? What are we worried about? What's going to be our first priority? A couple of things for priority questions. We're going to go by the nursing process. We're going to use Maslow's hierarchy of needs, prioritizing our physiological needs over our psychological one. And of course, most importantly, save the best for last, use those ABCs, airway, breathing, and circulation. So go ahead and drop those answers in the chat. Let us know what you all are thinking. A reminder to share and follow. Make sure you get all of your use out of this live. Give us a follow so you don't miss ones in the future. And you can share it with other like-minded nurses or nursing students in your social media networks. All right, lots of answers coming in, and thank you for letting us know where you're joining from. I see someone from Nigeria. Welcome, we're happy to have you. Someone joining from Kansas, thank you so much for tuning in. And I think that most of you got the gist of this question. You guys are correct. Option number 4 was our correct option. Way to go on this one. So when we first look at this, we see diaphoretic, lethargic, and disoriented to place and time. So a couple of things I'm worried about right off the bat. I'm starting to think about hypoglycemia. They're disoriented, lethargic, the diaphoretic means they're sweating, or it could be the potential for symptoms of a stroke. Now, whenever we're assessing this, we want to do our quickest, least invasive interventions first. We would want to make sure we confirm or rule out that low blood sugar or a hypoglycemic event before we pack this client up and wheel them all the way down to CT to assess for a stroke. So it's going to be much quicker, much easier, and much less invasive to do that just quick little finger stick, make sure we can confirm. And that's why options 1 and 2 are wrong. We never want to blindly give medications before we give a glucagon to increase the blood sugar and before we give an insulin, which would decrease our blood sugar. We want to make sure we know what the baseline is where we're starting out. Again, we're never blindly giving medications. If we didn't take the blood sugar and then we gave insulin, that exogenous insulin will pull glucose from the blood into the cell regardless of what our starting blood sugar is. So if they were already low, this has the potential to bottom them out and drop them even lower. So again, our correct option was that capillary blood glucose level because we're worried about hypoglycemia and we want to either confirm or rule this out first. So option 4 was our correct option. Way to go, you guys. You were not fooled by that one. Question 2, the nurse is reviewing new prescriptions for a client with end-stage renal disease. The nurse should clarify the prescription for metformin, erythropoietin, acetaminophen, or a phosphate binder. Again, clarify the prescription means which prescription are we worried about, would we not want to give, and could cause a complication for this client. Also, does anyone here scheduled to take their NCLEX? Let us know so we can wish you good luck. Is anyone here already taken the NCLEX and passed? Let us know so we can congratulate you all. We had a couple on yesterday's live that had just passed. I know that May is a big graduation season and June and July are typically really big testing seasons. So let us know what y'all's NCLEX plans are, who here is about to take it, who here has already passed. We would love to know. It looks like Ree on TikTok is taking it in July. Good luck. That's so exciting. I know there's more of you. You guys are going to do so well. If you're here studying with us today, then you're clearly on the right track. I see someone else on TikTok is taking it in June. Good luck. You're going to do great. It's right around the corner. Another June tester. Very exciting. And Andrina is waiting for her ATT I was in your shoes once. I totally understand that. Stay patient, it'll come eventually. Alrighty, so lots of answers coming in, and I see it looks like the majority of you guys agree the correct option is option number 1, that metformin. Let's see if it'll let me go. There we go. Sorry about that. So chronic kidney disease is going to be an irreversible condition characterized by a progressive decline in kidney function that persists for equal to or greater than 3 months. So how we grade CKD is going to be by glomerular filtration rate, or GFR, which essentially measures how effectively the kidneys are able to filter blood. As we move through the stages 1 through 5 of chronic kidney disease, that GFR is continually decreasing, getting worse and worse and worse. Unfortunately, the damage done in CKD is irreversible. There's nothing we can do to go back and gain that original function. So our clients in end-stage renal disease or end-stage kidney disease are in that. We cannot make them any better. That's irreversible damage. In this case, metformin is going to be contraindicated because with end-stage renal clients, it's excreted in the urine, and the buildup of this can cause that acidosis. So we would not want this because of the risk for acidosis. Our incorrect options would be erythropoietin, acetaminophen, and phosphate binders. These are incorrect because they're okay medications to give. Remember, this is a clarify question. We're looking for what's not safe for the client. 2, 3, and 4 would be safe for the client. Therefore, we would not have to clarify them with our provider. So that erythropoietin is something produced by the kidneys in a healthy kidney. It stimulates those bone marrow to produce red blood cells. This will be deficient in a client with chronic kidney disease, and especially a client in end-stage renal disease. So we would need to supplement and give it because the kidneys are not able to produce enough of it on their own. This would be correct. 3 is acetaminophen. So acetaminophen, not an NSAID, meaning this would be okay to give in a CKD client as long as we give it within healthy parameters. And lastly, that phosphate binder. These are medications used to reduce levels of phosphate in the blood, or hyperphosphatemia, which is common to have that buildup in our CKD clients. So again, option 1 was our correct option because we need to clarify it because there's a risk for complication with metformin in CKD clients. But great job, you guys. Alrighty, we have a long question here, but here the nurse is planning care for a client who has been newly diagnosed with type 1 diabetes mellitus and prescribed regular insulin. Which of the following intervention should the nurse include in the client's plan of care? Select all that apply. So 1 is teach the client to rotate injection sites with each administration. 2 is instruct the client to limit oral intake if the CAP blood glucose level is elevated. 3, remind the client that fruits and veggies do not need to be included when counting carbs. 4, instruct the client to check the CAP blood glucose level before meals and at bedtime. And 5, demonstrate to the client how to visually inspect the feet daily. Drop those answers in the chat. Let us know what you all are thinking. Another reminder, if you haven't already, or if you have, check out uworldnursing.com. This is like our home base for all of our UWorld Nursing social efforts. It gives you the times, the topics, and the channels that we plan to go live on each week. We have just added new lives in the evening times on Wednesdays and Fridays with Nurse Andrew. We're really excited about these because, first of all, he's great. He does such a great job explaining things, but also I know a lot of you guys are pretty busy in the day with work, maybe school, maybe taking care of kids. And so we want to offer an evening time that may be a little bit easier for you guys to sit and stay for the whole live if we go live in the evening. So make sure you check those out at 7 p.m. Central Standard Time on Wednesdays and Fridays with our friend Nurse Andrew. All right, I'm going to scooch over. I think my dome is getting in the way, you guys. Alrighty, so let's go ahead and jump to our correct options. I see lots of answers coming in. Great job, you guys. We're going to move on to 1, 4, and 5 is our correct option. So remember, in type 1 diabetes mellitus, this is an endocrine disorder characterized by the absolute lack of endogenous insulin production, that pancreas due to the autoimmune destruction of the pancreatic beta cells. So this insulin deficiency will lead to hyperglycemia and signs of cellular starvation, which can include things like fatigue and weight loss from that decreased glucose use, So in this case, we want to teach the client to rotate injection sites to prevent any scar tissue, transfer infection, and want to make sure we rotate that also to avoid like irritation and inflammation. This would be correct. We want to make sure we instruct the client to check the CAP blood glucose before meals and at bedtime. These are AC and HS checks. These are really common for an insulin regimen. 5 is demonstrate to the client how to visually inspect the feet daily. Diabetic clients are at a high likelihood of having that peripheral neuropathy. They may not have great sensation in their peripheries, specifically their feet, to be able to sense if they cut their foot, if they scrape their foot, if they stepped on something sharp. And we also have delayed wound healing in diabetic clients. So this puts this client at really big risk for getting some of those diabetic foot ulcers. These clients need to make sure they're instructed on proper foot care, which includes inspecting the feet daily for any sores that they would need to report. So 1, 4, and 5 were correct. We don't want to limit oral intake if we have that elevated blood glucose. DKA is a complication that can arise from diabetes, and one of the biggest issues with DKA is fluid volume deficit that can potentially lead to hypovolemic shock. So we don't want to limit the oral intake. We want to make sure they're staying hydrated, and remind the client that fruits and veggies do not need to be included when counting carbs. All carbs go to the carb count. We're not limiting anything. We're not taking anything out of that. That's an all-inclusive count. So 1, 4, and 5 are our correct options. Way to go, you guys. Alrighty, question number 4. The nurse is caring for a client with diabetes mellitus who is receiving insulin Lispro and insulin glargine. So which of the following statements by the nurse would require follow-up? 1 is insulin glargine reduces your risk of developing diabetic ketoacidosis or DKA. 2, I will wait to administer your insulin Lispro until your meal tray arrives. 3, insulin Lispro dosing depends on the number of carbohydrates you will consume. Or 4, I will check your CAP blood glucose level 1 hour after insulin glargine administration. Now, a little hint here, a great teaching point to figure this question out is to identify which of these insulins, are they long-acting, short-acting, rapid-acting, or intermediate. That's going to be kind of a hint for you guys to piece together our correct option. But again, keep those answers coming. You all have done so great today. Diabetes and endocrine questions can be challenging, but you guys have absolutely knocked it out of the park. A reminder that we also offer a UWorld question of the week feature. So a lot of you guys, if you're constantly on our social media, as I think it seems like some of you are, you see our question of the day feature that's so popular. Now we're also offering a question of the week. Go to uworldnursing.com for more information on how to sign up. This will be an email straight to your inbox every week that gives you one full NCLEX style question. Again, we're offering so many different types of free resources for all of our students, our test takers, so make sure you guys are taking advantage of these. Alrighty, and I see lots of answers and some people that are already explaining this. Someone got that glargine is a long-acting insulin. Way to go, you guys. That's going to be a big part of our teaching point here, which is why option number 4 is our correct option. So remember, this requires follow-up, meaning we're looking for a statement that's incorrect that requires some further intervention and teaching. So I will check your CAP blood glucose level 1 hour after insulin glargine administration. Remember, diabetes mellitus is going to be the endocrine condition characterized by a complete lack or a decrease in that insulin, depending on if it's type 1 or type 2. So we're going to need to put these clients, most clients, especially type 1 clients, are always going to be on an insulin regimen. Now, insulin Lispro is going to be a rapid-acting insulin. I think LIS sounds like less, i.e. less time, meaning it's a rapid-acting insulin because it works in less time. Insulin glargine, I think large like large or a large amount of time, therefore a large amount of time is a long-acting insulin. So that's a way I remember it. Maybe you guys have some different ways that work for you, but insulin glargine is going to be a long-acting insulin. It's going to help prevent hyperglycemia for 24 hours. So in this case, if we're checking that blood glucose just 1 hour after we're giving it, there's no pronounced peak onset here, so it most likely has not even taken effect yet. 1 hour is too early for us to get any pertinent information from this finger prick. So in this case, this would require follow-up because it's an incorrect statement. Options 1, 2, and 3 are correct statements, therefore they don't require follow-up. So insulin glargine reduces your risk of diabetic ketoacidosis. This is true. It's a longer-acting insulin, helps to prevent those spikes in blood sugar, which altogether will reduce the risk of DKA. 2 is wait to administer your insulin Lispro until your meal tray arrives. Also true. This is a rapid-acting insulin. It can really drop drop our blood sugar if we don't have food immediately available. So we're only giving this if that meal tray is right in front of them, ready to go to help avoid hypoglycemia. And lastly, 3, insulin lispro dosing depends on the number of carbohydrates you consume. This is true. We want to maintain a consistent carbohydrate intake, which is going to help dose our insulin as opposed to doing a lot and then a little and having those peaks and valleys. We want to keep it in the middle, nice and consistent. Alrighty, so option 4 was our correct option. Great job, you guys. Question 5, the nurse is preparing to administer insulin aspart to a client with diabetes mellitus. Which of the following actions would be a priority for the nurse to take? 1 is choose a site on the client's arm for injection. 2 is ensure the client eats within 15 minutes of receiving the injection. 3 is check the client's CAP blood glucose level in 1 hour. 4 is teach the client about signs and symptoms of hyperglycemia. Drop those answers in the chat. Let us know what you all are thinking. Another insulin question. So we're kind of doubling between endocrine and pharmacology, but we actually just did a pharmacology lecture for the NSNA webinar on Monday. So we are partnered with NSNA, the National Student Nurses Association. Now they have lots of different events they put on throughout the year. 2 of those are going to be their spring convention, which we went to in April in Seattle, and they'll have a fall one in Columbus, Ohio. We have a really big presence as their partner. We put on 8 hours of dedicated NCLEX review in April. If you're not able to make that, if you weren't able to join us in Columbus, no worries. We're offering virtual webinars as well. Visit our social media or the NSNA social media for more information on how to register. We're putting 6 on throughout the calendar year of 2025. We have 4 to go, the next of which will be Monday, June 9th. So make sure you tune in for that. We covered pharmacology in the last one. This upcoming one, I believe, are alternate item types, bow ties, and pediatrics. So if you're interested in any of those things, visit our social media for more information. But we love the NSNA. All right, lots of great answers coming in, and it looks like you guys got the majority of these as the correct option. So way to go, you guys. Number 2 is what I was looking for here. So aspart is another rapid-acting insulin, just like that lispro. So it's an onset of 10 to 30 minutes, so pretty quick here. Because that peak effect is going to take effect within 30 minutes to 3 hours, the nurse needs to ensure the client eats within 15 minutes of receiving this injection. This prevents those life-threatening hypoglycemic blood sugar drops that we want to avoid. So we always wait to give this until the meal tray is in front of them and they're ready to eat. Someone says, Felix on Instagram says, make sure the tray is there. You are absolutely right. And if you call nutrition and they say it's on its way, do not trust them until you physically see it. Because if you give the injection, I guarantee you there will be some kind of holdup in the kitchen. So 2 was our correct option because it's our priority. 1, 3, and 4, these were our incorrect ones. So we would not choose 1, choose a site on the client's arm for injection. While we do want to rotate sites, insulin absorption is going to be affected by the specific injection site. Absorption is going to be fastest and most consistent when it's administered in the abdomen. Then our next spots will be the arm, thigh, and buttock. So remember, a faster acting insulin, we want to put in a faster absorbing site like the abdomen. So our arm is not going to be our first choice. 3 is check the client's CAP blood glucose level in 1 hour. We check this prior to insulin administration so we can get a baseline. Usually rechecking the level in 1 hour is not going to be indicated unless hypoglycemia is suspected. A lot of times we see those 2-hour postprandial, so 2 hours after eating we would recheck, but it just depends on what the order is. And lastly, 4, teach the client about signs and symptoms of hyperglycemia, teaching the clients signs of hyperglycemia, of course, is important, but the client is eating within 15 minutes to prevent hypoglycemia. So really our most important thing here with a rapid-acting insulin, we're most concerned, our priority is going to be teaching about hypoglycemia or low blood sugar in this case. All righty. Question number 6. Y'all are doing great today. So here the nurse is assessing a client with hyperthyroidism. So we're finally out of our diabetes questions. Which of the following findings would be consistent with hyperthyroidism? Is it thinning hair and cold intolerance, palpitations and an elevated heart rate, weight gain and straining with defecation, or 4, fatigue and prolonged menstrual periods? drop those answers in the chat. Let us know what you all are thinking. And be sure, if you haven't already, give us a follow. We are moving into a big testing season, and we want to make sure you guys don't miss any of these free resources. We are putting so many out, so make sure you follow us so you don't miss them. And go ahead and share this live. It's not too late. I know a lot of you, if you're in school, probably have other nursing students, other nurses, other preceptors maybe in your social networks that could potentially benefit from this as well. Alrighty, so almost all of you guys are on the right track and you chose option number 2, which is correct. So hyperthyroidism is going to be the sustained hyperfunctioning, of the thyroid gland due to that increase in thyroid hormones T3 and T4, and they're going to have typically a decrease in thyroid stimulating hormone, because when the thyroid hormones are so high, we don't see a reason to keep stimulating the thyroid. That's why the TSH goes down, but our thyroid hormone increases in hyperthyroid. Of course, in hypo, it would be the opposite of this. So we're going to have hypermetabolic state here. So clinical manifestations occur like increases to the metabolism and oxygen consumption. The mnemonic sweating can be used to remember hyperthyroidism. So we're going to see sweating excessively or diaphoresis. Weight loss is the W. E is something called exophthalmos, which is the bulging of the eyes from the eye socket. This is because of increased fat and fluid deposits in those orbital and ocular areas. Clients can have amenorrhea or irregular menstrual cycles. We can see tachycardia and tremor, which makes sense for our correct option. Intolerance to heat, nervousness and insomnia is that N, and the G lastly is for gastrointestinal distress like diarrhea, as well as goiter. So lots of different things here. Palpitations and elevated heart rate both apply to hyperthyroid. Thinning hair and cold intolerance is incorrect. So we can see thinning hair in hyperthyroid, but cold intolerance is going to be associated with the opposite, hypothyroid, not hyper. Hyper is going to have heat intolerance. Remember, we're sweating. They can't tolerate a hot environment on top of that. 3, weight gain and straining with defecation. Weight gain is going to be consistent with hypothyroid. Hyper, we're going to see weight loss. And defecation or straining with defecation connotates like constipation, whereas in hyperthyroid, we're more likely to see diarrhea and that GI distress. Lastly, fatigue and prolonged menstrual periods, we're more likely to see amenorrhea, which is the lack of menstrual periods, or irregular cycles, not prolonged ones. That's going to be something more consistent with hypothyroid. So again, option 2 is the only option where both symptoms are consistent with the hyperthyroid diagnosis. Rosie asked if she can have a coupon for a discount. We are not giving out coupons, but we do have a 7-day free trial, so go ahead and check that out. Last question, you guys. The nurse is assessing a client with suspected hypothyroidism. So we're on the other end of the spectrum now. Which of the following findings would support a diagnosis of hypothyroidism? Select all that apply. So 1 is dry and brittle hair. 2 is unintentional weight gain. 3 is decreased serum T3 and T4 levels. Those are our thyroid hormones. 4 is decreased serum TSH. And lastly, 5 would be heat intolerance. So think about everything we talked about with hyper and think of the opposite. And for the most part, that's going to guide you pretty well for hypothyroid. Someone asked to repeat the mnemonic sweating means. So S was sweating and diaphoresis. W was going to be that weight loss. E was exophthalmos. A was amenorrhea. T was tachycardia and tremor. I was going to be irregular menstrual periods. I can't remember them all. And the G was goiter and GI distress. What was the N? Do you remember? Nervousness. Okay, I couldn't remember them all, but I got most of them. But yeah, I like that. I think you can Google that too. Honestly, sometimes I find a lot of good resources for nursing mnemonics. Pinterest actually has some, so in case you were looking. Alrighty. These are great answers coming in, you guys. Way to go, you guys. And I think the majority of you guys nailed this. 1, 2, and 3 was what we were looking for. So hypothyroidism is the sustained hypofunctioning of the thyroid gland. We're going to see this because of decreased thyroid hormone, being that T3 and T4, as we see in option 3. This is often autoimmune related. This can be caused by Hashimoto's thyroiditis, or the surgical removal of the thyroid in treatment for hyperthyroid can put a client into hypothyroid. So clients exhibit those manifestations of a low and a slow metabolic rate. These include fatigue, decreased libido, mood changes, bradycardia, weight gain, hypotension, cold intolerance, constipation, weight gain, periorbital edema, and they can have that dry and brittle hair as well. So 1, 2, and 3 were our correct options. 4 and 5 are incorrect. Heat intolerance is consistent with hyperthyroid, and decreased TSH is going to be consistent with hyperthyroid as well. Hypothyroid will be increased TSH because we're trying to get that thyroid working, and decreased thyroid hormone being T3 and T4. So great job, you guys. Way to go. Let us know how many out of 7 you all got correct today. Thank you so much for joining. We're actually back tomorrow morning with a hyperthyroid concept map, which is the first time we're doing it live. I'm super excited to do this for you all. Please join us tomorrow at 11 a.m. Central Time. Bye, guys.